Thank you so much for the kind invitation. It's an honor and a privilege giving this talk on EEG in critically ill patients in the intensive care unit and in the emergency room. So undoubtedly, this is probably the most dynamically developing clinical application of EEG. The number of centers monitoring EEG in the ICU and the number of publications has increased exponentially. But where are we in the hype cycle of this technology? Are we still at the peak of the inflated expectations, or have we already reached the plateau of productivity? I will do my best to give you a comprehensive and balanced view on the state of the art of EEG in critically ill patients. This is the outline of my presentation. I will talk about seizures and status epilepticus, subarachnoid hemorrhage, prognosis in post-anoxic patients, and in the end, I will give you my minimalistic summary on this topic. Well, let's start with the seizures and status epilepticus, and this is the largest part of my presentation. I'm going to talk about indications for doing EEG in patients with altered consciousness, continuous EEG or repeated routine EEG. I will talk about the EEG criteria for seizures and status epilepticus, and also about EEG patterns indicating increased risk of seizures and status epilepticus. I will talk about the clinical relevance for the therapy and outcome. So what are the indications for doing EEG in patients with altered consciousness? In this green box, I will show you those indications that are backed up by a broad consensus. So everyone would agree that we need to do EEG if there is a suspicion of non-convulsive status epilepticus, because EEG is needed to confirm the diagnosis of non-convulsive status epilepticus, and there are some clinical red flags that raise the clinical suspicion of non-convulsive status epilepticus in a patient with altered consciousness. So if a patient with altered consciousness is known to have epilepsy, then that's a red flag. A long post-ictal phase after a convulsive seizure, that's also a red flag that it's actually a non-convulsive status epilepticus following a convulsive seizure. And of course, the presence of subtle seizures is also a red flag. These are discrete clinical manifestations which on their own do not prove that the patient has status, because they can occur in other conditions caused by medication or by the etiology. A high index of suspicion for non-convulsive status epilepticus and a low threshold to obtain EEG is recommended. The other indication is if the other clinical and paraclinical data do not explain the altered consciousness. EEG here is needed for differential diagnosis, non-convulsive status epilepticus versus acute encephalopathy versus a psychiatric condition in patients with rapid and unexpected emergence of altered mental status in the absence of another plausible explanation. In patients with altered consciousness but no clinical signs of seizures, EEG has detected non-convulsive status epilepticus in 8% in the intensive care unit and more than 1/3 of the patients in the emergency room. Now, in the yellow box, I will show you the indications that are controversial, and there are different opinions on the two sides of the Atlantic. So the other clinical and paraclinical data explain the altered mental status, but they say that the non-convulsive status epilepticus worsens it. Practically, this means an indication in all critically ill patients almost. And then another indication could be the monitoring of the therapeutic effect monitoring of burst suppression in refractory status epilepticus in patients who receive third-line anesthetics for the treatment of refractory status epilepticus. Among critically ill patients admitted to the ICU, almost 30% of the patients monitored with EEG had non-convulsive status epilepticus. So it pays off putting on EEG because you catch them. Non-convulsive status epilepticus is the admission diagnosis for only a small subset of patients in the ICU, because most patients develop non-convulsive status epilepticus after the acute clinical illness. So, continuous EEG or repeated routine EEG. Again, a discordance between the two sides of the Atlantic. So we know that continuous EEG improves seizure detection, but it's really resource consuming. And it's uncertain whether it improves the outcome. The only prospective multi-center randomized trial, the CERTA trial, failed to prove the utility of the CEG. In this study, adults with altered consciousness without recent seizures or status epilepticus were recruited. They were randomized 1-to-1 to continuous EEG or to 2 routine EEGs of 20 minutes each. Of course, continuous EEG increased seizure detection, and it also increased modification of anti-seizure treatment. Yet there was no difference in the outcome at 6 months. There are several large retrospective studies, but the results of those studies are controversial concerning the outcome. So let's talk about the EEG criteria for seizures and status epilepticus. Well, in this box, I will show you my crystallized minimalistic criteria. So in the ICU in critical ill patients, ictal EEG patterns are the ones you already know from patients with epileptic seizures. So this is not a big hocus pocus. Think of how a seizure looks like and look for that also in an ICU patient. In 2013, we proposed a set of criteria for non-convulsive status epilepticus, which are now known as the Salzburg criteria for non-convulsive status epilepticus. And then in 2016, we published a multi-center validation study showing that the Salzburg criteria have high inter-rater agreement, really high sensitivity, close to 100%, and a reasonable specificity around 90%. So let me guide you through the Salzburg criteria. So the entry point is a clinical suspicion of non-convulsive status epilepticus, and this is very much based on the ILA task force new definition and classification of status epilepticus. So you need at least 10 minutes of clinical symptoms. Now this is the entry point. Then you do the EEG. And then if you see in the EEG epileptiform discharges and their frequency is more than 2.5 Hertz, then you can say the patient has non-convulsive status epilepticus. This is the easiest way of fulfilling the Salzburg criteria. Okay, but what if the frequency of the epileptiform discharges is under 2.5 Hertz? And what if you see other rhythmic patterns? Well, in that case, you need at least one secondary criterion, and you can see the secondary criteria in this gray box. Now, the first one is the typical spatiotemporal evolution. And again, think of what a rhythmic ictal pattern looks like in a patient with epilepsy. It evolves, it changes in time and space. So if you can see the same dynamic ictal evolution, then you can say that the patient has non-convulsive status epilepticus. Now, the following criteria are more characteristic for what you can see in the ICU or in the emergency room. So if there are subtle clinical phenomena like discrete jerks or eye deviation or tiny automatisms, and these are time-locked to the EEG patterns, then you can diagnose again non-convulsive status epilepticus. If you are still in doubt, you can try an intravenous anti-epileptic drug. And this is not for the treatment. This is to check the modulatory effect of the intravenous anti-epileptic drugs on the EEG and the clinical status. So if this modulatory effect is positive, so you can see a definite improvement in the EEG and in the clinical status, then you can diagnose non-convulsive status epilepticus. Now, if there's only an EEG improvement, which is often the case in the ICU as opposed to the emergency room, but if you only see an EEG improvement, then this is a possible non-convulsive status epilepticus according to the Salzburg criteria. Now, if you see the fluctuations, so it's not a gradual evolution in the same direction, but if you see a fluctuation back and forth in the EEG pattern, then again, that's a possible non-convulsive status epilepticus. I will show you examples. This is just the overview of the algorithm. Now, one more issue. So how long does this need to be there? Well, please remember that we have a 10 minutes criterion already in the input, but that's a clinical duration. Now, the EEG pattern fulfilling the Salzburg criteria must be there for at least 10 seconds. But again, 10 seconds is just for this maximum of the EEG abnormalities. It's not for the clinical duration. That must be at least 10 minutes. Now, we have some additional criteria for the patients with known epileptic encephalopathy. Why? Because they have a horrible EEG already in the baseline, and we don't want to overtreat them. So these patients, these children with epileptic encephalopathy, must fulfill at least one of the following two additional criteria. So there must be either an increase in prominence or frequency of the features, EEG features mentioned above, when compared to the baseline EEG. Unfortunately, we usually have previous EEGs on these patients. Or there must be an improvement of the clinical and EEG features with intravenous anti-epileptic drugs. So basically, you make compulsory this branch of the Salzburg criteria. So the American Clinical Neurophysiology Society has recently published an updated version of their terminology for the EEG in critically ill patients. Now, the new ACNS guideline defines also seizures and status epilepticus. This is a new feature in the ACNS guideline. And this is mainly based on the Salzburg criteria. There are some changes because in the ICU, typically, you cannot rely on the clinical duration, which was the entry point for the Salzburg criteria. So you need to use EEG to define the duration. This is the first change. And then the primary criterion and the first secondary criterion are the electrographic seizures or status epilepticus. And then if a subtle clinical phenomenon is confirmed to be of epileptic origin by being time-locked to the EEG pattern, then this is an electroclinical seizure or status epilepticus according to the new ACNS guideline. And if there is an EEG and clinical improvement with this modulatory trial of intravenous anti-epileptic drugs, then again, this is an electroclinical seizure or status epilepticus. If there is only an EEG improvement, then it's a possible electroclinical seizure or status epilepticus. And fluctuation goes now into the ictal interictal continuum. I will talk about that later. Okay, so let's see how the ACNS guidelines define seizures and status epilepticus. So we have the electrographic seizures or status epilepticus with the two archetypical patterns. The epileptiform discharges continuously there with a frequency higher than 2.5 Hertz, and the pattern with evolution in time and space, this temporospatial dynamics. And then we have the electroclinical seizures or status epilepticus. So there is a clinical correlate time-locked to the EEG pattern. This can be subtle. Or a clinical and EEG improvement with intravenous anti-epileptic drugs. If it's only EEG, then it's just possible. Okay, the duration. So if it's only 10 seconds, then it's a seizure. If it's 10 minutes in one block, then it's status epilepticus. Or if it's fragmented, but you sum up the minutes during 1 hour to 20% of an hour, so that's 12 minutes, then it's again status epilepticus. Okay, let me show you some examples. So here you can see this continuous bilateral synchronous spike and wave activity. Frequency is beyond 2.5 Hertz. So this is absence status epilepticus. Now you can see again these periodic discharges. They are sharp and their frequency again is beyond 2.5 Hertz. So you have status epilepticus in a patient with coma. And here you can see again the continuous spike and wave activity, but this time it's focal. Here you can see it in a common average montage in the parietal area. And here you can see it in a longitudinal bipolar montage. Again, spike and waves frequency beyond 2.5 Hertz. Now, this is the dynamic evolution that I have mentioned earlier. So I used to tell my students that an ictal rhythm has an evolution. It's alive. It's not a monomorphic dead rhythm. So here you can see in this common average montage that it starts here in the left anterior temporal region with a high frequency and a low amplitude. Now follow this in time. And you can see that gradually the frequency changes, gradually the amplitude changes, and gradually the morphology changes. So this is the evolution in time. And then the evolution in space, that's the propagation. So it starts on the left side, but then it propagates also to the right side. So this is the spatiotemporal dynamics, the evolution of the ictal rhythm. Here I compress the EEG more so that you can estimate the evolution. So here you can see the evolution in time. So please note the gradual change in amplitude and frequency, and then look at the propagation. And this is the evolution in space. And this is the same in a longitudinal bipolar montage. This is another seizure. So again, you can see the evolution in time, the gradual change in frequency and morphology, and then the propagation, the evolution in space. And the same here in longitudinal bipolar montage. Now, let me show you these subtle seizures. So these are tiny, discrete clinical manifestations, which on their own do not yet prove that this is caused by an epileptic activity. So please observe the tiny jerks, the perioral jerks in this patient. So this is a subtle seizure. And here the jerks in the left. So we tried to extract features from the semiology, which would prove that this is of epileptic or another origin, and we could not. We looked at the semiology, we looked at the localization, the somatic localization of these patterns, their occurrence. We could not, just based on semiology, distinguish between non-convulsive status epilepticus and other causes like medication and the etiology behind the patient's altered consciousness. So to prove that these are of epileptic origin, you must do an EEG. Now let me show you another example. So this is a patient with myoclonic status. Here you can see the EEG discharges time locked to the myoclonus. So again, this fulfills our criteria. And again, time locked to the clinical manifestation. Now, the next one. So here in the right central area, you can see this polymorphic delta activity. Well, on its own, this would not mean that the patient has seizure or status epilepticus yet. Look at these green electrodes. These are the surface EMG electrodes, and you can see time locked jerks. And now let me show you the video too. So again, this is just a polymorphic delta activity, but time locked to it, you can see the jerks in the left arm. Okay, this patient has polyspikes continuously, but their frequency is not high enough to qualify for seizure or status epilepticus. Why? Because this is under 2.5 Hertz. Okay, we try to give intravenous anti-epileptic drugs and the abnormalities disappear. And very importantly, the background also improves. So this qualifies already for a possible non-convulsive status epilepticus. And then if you also see a clinical improvement, then it's a definite non-convulsive status epilepticus. Okay, but let's see those patterns that do not indicate seizures, but indicate that there is an increased risk of seizures and status epilepticus. And here we need to talk about the terminology used by the ACNS. And here probably you're familiar already with this. Here we have the two main terms, where main term 1 is about the localization. This could be G for generalized, L that is lateralized, BI that's bilateral independent, UI, this is a new one, unilateral independent. So you have two foci in the same hemisphere and they are independent of each other. And MF, that's multifocal. That means you have at least 3 different locations independently in both hemispheres. And then the main term 2 is about the pattern. Is this a periodic discharge, a rhythmic delta activity, or SW stands for spike, polyspike, and waves, and also for sharp and waves. So this is a pictogram of the periodic discharge. So please note the discharges, and please note that there are intervals between the discharges. So this is very important. A PD has interval between the discharges. Then you need at least 6 discharges in a row to qualify. Now, let's see what's in between these intervals. Is this a periodic discharge or is this a burst? Well, discharges are either shorter than 0.5 seconds, so anything shorter than 0.5 seconds is a discharge. Now, if it's longer than 0.5 seconds, but it has no more than 3 phases, then it's still a discharge. And you call this a burst if it is longer than 0.5 seconds and it has more than 3 phases. And then there are the patterns where there is no interval between the discharges. So there is the rhythmic delta activity. So one delta wave is followed immediately by another delta wave. There's no interval here. And the SWs, like a spike wave here. And again, there's no interval. These are following each other. And then we have the plus features. And these are additional features which render the pattern more ictal appearing than the main term without the plus. Of course, it does not apply to SWs because those are enough ictal. And these modifiers are a superimposed fast activity plus F. This must be at least a theta frequency band. And this applies for the periodic discharges and for the rhythmic delta activity. Plus R is the superimposed rhythmic delta activity, and this applies for the PDs only. And plus S, that is the frequent, at least one per page, superimposed sharp waves or spikes or sharply contoured waves on the rhythmic delta activity only. So it does not apply to the PDs and SWs. So we can have for the PDs plus F, plus R, and this combination of fast and rhythmic. And for the rhythmic delta activity, we can have the following plus modifiers: fast, the sharp, and the combination of the two FS. Okay, let me show you some examples. So here you can see in this longitudinal bipolar montage, this periodic discharge. So note the interval between them. They resemble each other, and the period interval between them is approximately the same. Now, please note that this is lateralized, so we can see it only on the right side, which we have in blue. on the continent. So here we have these periodic discharges, and please note the superimposed fast activity. So this is with superimposed fast activity. Now, the next one, again, periodic discharges, and again, lateralized. Lateralized periodic discharges on the left side. So here you can see in this longitudinal bipolar montage, the rhythmic delta activity. It's a lateralized, it's only on the right side. And then here you can see that there is a sharp wave here. So there is a plus modifier, plus S for the sharp wave. Now here you can see again rhythmic delta activity, but now it's generalized. It's bilateral synchronous. And then you have a plus modifier again, you have a sharp wave. You could also say it has triphasic morphology. So these are generalized rhythmic delta activities. Now, again, you can see very nicely the lateralized periodic discharges. So you can see very nicely on the left side, which we have in red, these periodic discharges. These are quite spiky. Okay, again, periodic discharges, but this time they are bilateral, synchronous, so they are generalized periodic discharges, GPDs. And then here you have the lateralized spike waves. So spike waves, but only here on the left side, lateralized spike waves. And here you have bilateral, but independent periodic discharges. And there is also a fast superimposed activity. So there is the plus modifier. Now, we know from this large American study which patterns suggest increased risk for seizures. So regardless of the frequency, the lateralized periodic discharges indicate an increased risk of seizures. And of course, the higher the frequency, the higher the risk. Now, for the lateralized rhythmic delta activity, they increase significant risk for seizures if their frequency is higher than 1.5 Hertz, and that applies also for the generalized periodic discharges. And generalized rhythmic delta activity does not indicate an increased risk for seizures or status epilepticus, regardless of their frequency or the superimposed plus modifiers. Now, there is another important pattern that has been added now to the new ACNS guidelines, and these are the brief potentially ictal-rhythmic discharges, or the BIRDs. These are focal or generalized, sharply contoured rhythmic activity. Their frequency is beyond 4 Hertz. Now, their duration is at least 0.5 seconds, and the maximum duration is 10 seconds. Why? Because if they are longer than 10 seconds, they would qualify actually as a seizure. They are not consistent with a known normal pattern or a benign variant, and they are not part of a burst suppression or burst attenuation. And of course, there is no clinical correlate. Otherwise, they would qualify as seizures. Now, the definite BIRDs have an evolution. So you've already learned the spatiotemporal dynamics typical for seizures. So you can see this within the bird, and that makes them a definite bird. Or they fulfill also the criteria for definite bird if they are in the same location where you can see interictal discharges. Now, if they are just spiky or sharply contoured, then they are possible birds. These patterns, birds, are associated with seizures. So if you see birds, then 75% of the patients have seizures. And if you don't, then it's just 25% in this study of you. So here you can see the birds. Here in the left temporal area, you can see they are spiky. There is an evolution within it, and they are in the same location as the interictal epileptiform discharges. And this is the same in a longitudinal bipolar montage. So the 2 helps to be score helps you to predict whether the patient would have seizures or not if you continue the EEG, if you record a longer EEG. And 2 helps to be is actually an acronym, and it stands for the following: 2H, that stands for rhythmic and periodic patterns with a frequency beyond 2 Hertz. E stands for sporadic epileptiform discharges. L stands for lateralized patterns like LPDs, BIPDs, lateralized rhythmic delta activity. P stands for plus features, so plus fast, rhythmic, or sharp. S stands for previous seizures. Now all these give 1 point. And then the 2B at the end, that's for the bursts. And the 2 means that you give 2 points for it. Now, the total score can vary between 0 and 7. So if the score is 0, then there is only a 5% seizure risk. And this gradually increases. So if the score is 6 or 7, then you have almost a certainty, 95%, that the patient would have seizure later on. So you can use these to determine how long you need to record EEG. So you start with a 1-hour screening. And then if the 2 helps to be score is 0, then you can stop. Because if you accept a false negative rate of 3%, which is nothing. So if you accept this, then you can exclude that the patient will have seizures or status epilepticus. Now, if the score is 2, then it's indicated to switch to continuous EEG because the patient with high certainty will develop seizures or status epilepticus. Now, in between, you have this score of 1. Well, here there is an increased risk, but you need to continue just for 12 hours. Now, if it stays at 1 or goes back to 0, then you can stop. But if during this 12 hours recording, it increases to 2, then you continue with the continuous EEG. Another important new feature in the ACNS guideline is the so-called ictal-interictal continuum. I must say its significance is still unclear. It could be a possible electrographic seizure, so we need more research to elucidate what this is. Now, it's defined as those patterns which are close to being ictal, but they do not fulfill actually the criteria for seizures or status epilepticus. So if you have these spike waves or periodic discharges close to the threshold of 2.5, but they don't reach it. So you have it for at least 10 seconds, but the frequency is just between 1 and 2.5 Hertz. Okay, you can go even a little bit further down with the frequency to 0.5 to 1 Hertz, but then you need either a plus modifier or a fluctuation. I will show you immediately some examples with fluctuation. Or if you have lateralized rhythmic delta activity with a frequency beyond 1 Hertz, and of course longer than 10 seconds, and a plus modifier or fluctuation. And of course, they must not qualify for seizures and status epilepticus, so then you call them ictal-interictal continuum. Again, the significance is uncertain. They could be electrographic seizures, so you should assess the modulatory effect of intravenous anti-seizure medication if you see these patterns. So like this example where you can see this periodic discharge, their frequency is 2 Hertz, so they do not qualify for a seizure, but they are close to it. So now we would say that this belongs to the ictal-interictal continuum, and we would try to see the modulatory effect of intravenous anti-seizure medication. Now, I mentioned the fluctuation. So you remember the evolution is a gradual change, several steps in the same direction. Now, fluctuation is a kind of ping pong back and forth. So for example, you start with the 2 hertz and then 2.5 hertz, but you don't go to 3, but you come back to 2. So you oscillate between these 2 frequencies. So it's a fluctuation and not an evolution. Here, for example, you can see a very nice fluctuation. So this ping pong between this frequency and higher frequency, and then back to this in this common average montage. And now here you can see it also in a longitudinal bipolar montage. So this is a fluctuation. Okay, so what's the clinical relevance of all these dangerous EEG pattern seizures and status epilepticus? Shall we treat them, or we do not need to treat them? Well, this brilliant diagram by Bauer and Trinka and Leitinger, I think, shows you quite accurately what you need to focus on. Let me explain this. So on the horizontal axis, you have the degree of unresponsiveness. So you have a slight degree of unresponsiveness. Patient is mainly disoriented. And here you have a comatose patient. Now on the vertical axis, you have the interplay between either epileptic brain dysfunction, so this is mainly in this left side, or the proportion of structural brain damage. And here you have the transition between the 2 extremes. Now, the prognosis worsens in this direction. So at the one end of the spectrum, you're in this corner, you have the absence seizures in patients with idiopathic generalized epilepsy, delayed de novo absence status, or atypical absence status. Here the prognosis is good. Here you will see typically both an EEG and a clinical improvement when you give intravenous anti-epileptic drugs. Now, at the other extreme, you have this corner with a big proportion of structural damage and a comatose patient. So you have the coma with generalized periodic discharges, lateralized periodic discharges. Here the prognosis is poor. And then, of course, you have the various syndromes in between, like the focal status epilepticus with impaired consciousness, aura continua, status aphasicus. So here you already have some structural brain damage component, but still you have the majority of it with the epileptic brain dysfunction. Or getting closer to the coma, you have the acute symptomatic focal status epilepticus, epilepsia partialis continua, and then subtle seizures. Now, recently, the Telstar study has been published. This was a prospective multicenter study on post-anoxic patients, comatose survivors of the cardiac arrest, a large patient population, which was randomized 1-to-1 either to anti-seizure treatment group. This was with a stepwise strategy of anti-seizure medication to suppress the rhythmic and periodic patterns for at least 48 hours, consecutive hours, plus, of course, the standard care. And then the control group, that was just standard care alone. Well, there was no difference in outcome at 3 months, no difference in mortality, and no difference in poor neurologic outcome. And I would like to mention also this recently published study in neonates. The authors included, again, prospectively a very large population, and they randomized the neonates into those who got amplitude integrated EEG, and the other group where seizures were spotted only with clinical observation. And there was no difference at 2 years outcome. No difference in survival free of severe disability. So this shows how wise the ILAE task force was when they issued the new classification of status epilepticus in 2015, because they've already there distinguished between non-convulsive status epilepticus with coma and non-convulsive status epilepticus without coma. Treatment in non-convulsive status epilepticus in patients with epilepsy, that's a clinical standard. But the treatment of non-convulsive status epilepticus in patients with coma that has still an uncertain benefit because all three prospective randomized studies aiming at suppressing electrographic seizure patterns in patients without previous epilepsy or seizures failed. And this was the Telstar study in the post-anoxic patients, the CERTA study in adults with altered consciousness, and the study by Hunt et al. In the neonates. So let's talk briefly now about the subarachnoid hemorrhage and the delayed cerebral ischemia. So as you well know, the delayed cerebral ischemia or vasospasm is a common and disabling complication of subarachnoid hemorrhage, which occurs 4 to 14 days after the hemorrhage. It can be treated and prevented using nimodipine, a calcium channel blocker. However, this carries risks when applied indiscriminately. Of course, you can show transcranial Doppler to show the vasospasm, but this investigation is intermittent and it only has a modest accuracy. Nevertheless, the continuous EEG continuously monitors the activity of the brain, and a prospective study showed that with high accuracy, it can predict the delayed cerebral ischemia, and you can see the EEG changes already almost 2 days before it occurs. In both the low baseline and high risk baseline groups, it had a high sensitivity and good specificity. And a large retrospective study showed that doing CEG was associated with decreased mortality in subarachnoid hemorrhage. Now, these are the features that you have to spot when looking at the EEG in a patient with subarachnoid hemorrhage. So you have to look for the worsening in the focal slowing, the worsening in the alpha-delta ratio, the worsening in the relative alpha variability, and of course, you have to look for new epileptiform abnormalities. Now, this is the relative alpha power variability. So it's calculated from the power in the 8 to 12 hertz frequency band divided by the power in the 1 to 20 hertz frequency domain. So each of these bars is calculated over a period of 30 seconds. So we can see that this is an excellent variability. This is good. This is a good variability. This is a fair and no real variability here. So this is poor relative alpha power variability. Here you can see the alpha delta power ratio. So this is calculated over 2 minutes windows. So you divide the power in the 8 to 13 hertz frequency band with 1 to 4 hertz frequency band. And here you can see a decrease in the alpha delta ratio, and then it increases, it comes back to normal, but only on the right side depicted here in red. And here you can see that on both sides, the alpha delta ratio decreases. Okay, let's talk now about the prognosis in post-anoxic patients. So EEG continuity predicts outcome in the post-anoxic coma. This applies if you do the EEG at 12 hours after the return of the spontaneous circulation. So if you see generalized suppression or burst suppression, that means a poor prognosis with a very high specificity, but a modest sensitivity. Continuous EEG means a good prognosis, again, with a relatively high specificity of 91% and a good sensitivity. So what is not continuous? How do we assess the continuity of EEG? Well, what is not continuous is either suppressed. Suppression is under 10 microvolts, or attenuation that is higher than 10 microvolts, but these attenuated periods have an amplitude drop of more than 50% compared to the rest of the background voltage. So EEG can be either continuous, or if you have these not continuous periods for up to 10%, then you have nearly continuous EEG. If these not continuous patterns are up to 50%, then you have a discontinuous EEG. If they are more than 50%, then they are either burst suppression or burst attenuation, depending of how the pattern is. And then if it's totally gone, then it's suppressed, then it's a suppression. And again, of course, this is bad prognosis and this is good prognosis. So here you can see suppression. Here you can see the burst suppression. And here you can see another pattern which has a poor prognosis. These are the identical bursts. So if you can see a burst suppression and then the first part of the bursts are identical, then this means a very poor prognosis. EEG reactivity is also an important aspect for the prognosis. And here the lack of reactivity means a bad prognosis. But you have to do standardized testing of the reactivity. So you need to have at least 2 minutes between the stimulation. Then you need 15 seconds of artifact-free baseline before the stimulation. And then you must do the stimulation for at least 15 seconds for each stimulation. And then you need to do 3 nociceptive stimulations, fingernails, sternum, nipples, processus mastoideus. You need to do passive eye opening and also acoustic stimulation. So here you can see the change. It's usually a desynchronization that you have to spot. So here you can see a desynchronization, a change in the frequency with the stimulation. Now, in the end, let me give you my minimalistic summary about EEG in critically ill patients. So you can do EEG in non-convulsive status epilepticus. You must do it because otherwise you cannot diagnose non-convulsive status epilepticus. And then you need to identify the so-called electrographic rhythms, so the spike waves with a frequency higher than 2.5 Hertz, or you can spot evolving rhythms qualifying for an electrographic pattern, or you need to see an electroclinical seizure status epilepticus. So remember, these are the time-locked subtle seizures, time-locked to the EEG pattern. And the other way to fulfill this criterion is to see a clinical and electrographic improvement on intravenous anti-seizure medication. Then please remember to use the 2 helps 2B score to determine whether the patient has an increased risk for seizures or status epilepticus. Concerning treatment, well, in patients with epilepsy, this is a clinical standard. In patients with coma, it's still uncertain what the benefit is. The other area or the other indication for doing EEG is in subarachnoid hemorrhage. Here you can use EEG to predict the vasospasm, and you need to keep your eyes on the focal slowing, decreased relative alpha variability, alpha delta ratio, and you need to also look for new epileptiform activity. In post-anoxic patients, you can use EEG for prognosis. EEG continuity is good. Lack of EEG reactivity is bad, and the identical bursts also indicate a poor prognosis. And with this aerial view of Aarhus and Aarhus University Hospital, I would like to thank you for your attention.